Welcome back to Deep Dive Ortho. This is the show for you, the clinician, the consultant, the surgical team, and indeed the policymaker trying to navigate the really shifting landscape of global medicine. For decades, when we talked about cross-border care or medical tourism, the conversation was always about the tangible things, wasn't it? New surgical theaters, faster jets, maybe some pioneering anesthesia techniques. But the real transformation that's reshaping patient safety today, it's almost completely invisible. So today we are launching into a deep dive on what you could call the emerging digital backbone of international healthcare. We're going to dissect exactly how tools like advanced electronic health records, sophisticated telemedicine, and remote monitoring are, well, they're not just improving convenience, they are fundamentally redefining patient safety and tackling the massive challenge of sustainability. Our mission is to move past the hype and really explore this new infrastructure with the rigor it deserves. And there is absolutely no one better to help us unpack this than our guest today. Professor, thank you for joining us.
It's a genuine pleasure to be here. This topic is so critical. What we're talking about today is really moving from a nice-to-have to a mandatory piece of infrastructure.
Mandatory, that's a strong word.
I think so. For any organization involved in cross-border care, having robust digital governance and infrastructure, it's now a precondition for ethical, safe clinical practice.
Indeed. And for our listeners, we're focusing on the practical reality. This means understanding the clinical benefits, better pre-optimization, fewer prescribing errors, but also staring squarely at the professional hazards. I mean, the huge exposure from cybersecurity attacks, the complex regulatory liability when data crosses continents, and that persistent challenge of algorithmic bias when you're dealing with diverse populations.
That is the crux of it, exactly.
Yeah.
We're not just discussing tools, we're discussing risk vectors and governance frameworks. The challenge is ensuring these systems are built not just for commercial efficiency, but specifically to elevate patient safety standards across borders.
Okay, so let's unpack that. This idea of a shift in infrastructure. The old paradigm was physical, the bricks and mortar of a new hospital. But you're arguing the new one is invisible infrastructure. So secure data systems, telehealth platforms. What does that actually mean for the patient's journey?
It means a fundamental shift in the timeline of that journey. The patient's experience used to begin, really, when they landed at the destination airport.
Right.
Now it starts the moment they open their laptop. A patient in Manchester researching orthopedics in Germany, or someone in the UAE looking for oncology in the US. That first engagement is always digital. These are the new digital touch points. You've got comparison websites, social media groups offering peer advice, and then, of course, the video consultation.
And they're sharing sensitive data right from the get-go.
Critically, yes. They're expected to upload previous op notes, imaging files, pathology reports, often before any real clinical vetting has even begun.
Because these are much more than just marketing funnels. They're effectively the new front door to the clinical pathway.
Absolutely. And that is precisely why their management is so critical. When these digital touchpoints are professionally governed, they immediately enhance clinical safety. They allow for verifiable, high-quality documentation to be gathered ahead of time.
Which would then refine the preoperative risk assessment.
Significantly. That clarity, knowing the patient's full history before travel is even booked, it strengthens the patient experience by setting realistic expectations from the start.
That makes perfect sense. But I have to ask, if these platforms are commercially driven or lightly regulated, doesn't that introduce a whole new set of risks for the patient right at that initial stage?
That is the real professional friction. Poorly regulated intake systems, where the main driver is, profit. They just make information gaps worse. They encourage data sharing without properly securing it, which introduces huge data safety and privacy risks right at the outset.
So we need to see them as clinical infrastructure.
We have to. They require the same level of governance and audit as a physical hospital.
Let's drill down into the main tool here, which is telemedicine. We know it covers the full spectrum pre-travel, in-country, post-travel. But for our clinical audience, what are the high-stakes safety implications at either end of that journey?
Well, telemedicine is functionally an extension of the consulting room. It can be synchronous video, asynchronous messaging, or store and forward for reviewing images. It performs critical suitability functions all the way through. Let's take the pre-travel stage. That virtual consultation is absolutely vital for a high-quality risk assessment. A surgeon can conduct a detailed virtual history and physical, review structured data on comorbidities, medications.
And refine the ASA score preemptively.
Precisely. If a patient's class is higher than first thought, the risks of long-haul travel DVT, the stress of flight on the cardiovascular system, might actually outweigh the benefits of having the procedure abroad.
So the goal isn't just to facilitate travel anymore, it's to prevent unsafe travel. It's a clinical filter.
Exactly right. It allows the clinician to determine if travel is truly medically appropriate, or if a perfectly good alternative exists closer to home. This better selection process makes things much more efficient for providers.
Fewer last-minute cancellations, I imagine.
Fewer cancellations, fewer resource-intensive surprises on arrival. But most importantly, it makes it safer for the patient. And then you have the other end of the journey, that historically problematic post-travel phase. We call it the aftercare gap. Patient gets home, they're vulnerable, they're miles from the operating team.
And their local GP often has no idea what actually happened in theater.
Exactly. So video follow-ups allow the surgical team to remotely assess wound healing, review new symptoms, and coordinate medication changes with local doctors.
That must provide immense reassurance, but it's also about objective data, isn't it? How often does that remote link catch a complication early?
It is often the key differentiator. Without that link, a patient might ignore subtle early signs of a problem. With it, the team they trust can look at a high-res photo of the wound and say, yes, that's healing as expected, or no, that redness warrants an immediate trip to your local A&E for blood tests.
It replaces guesswork with a structured, documented consultation.
It replaces fuzzy memory with visual evidence.
It's invaluable. Okay, let's pivot to something that makes this a major policy discussion: sustainability. The environmental footprint of medical travel is huge. As clinicians, how can we realistically quantify and incorporate the environmental benefit of virtual care?
This is where we see what's being called the tele-first model. It aligns clinical safety with global policy goals, like the NHS's commitment to achieving net zero carbon emissions.
Because every trip you avoid saves carbon.
A huge amount of carbon. Traditional medical tourism is built on air travel, which is incredibly carbon intensive. Every single physical trip that we can safely replace with a virtual consult translates directly into quantifiable carbon savings. And when you look at the evidence, the reviews, the estimated savings per telemedicine session are, well, they're compelling. It could be as little as a kilogram of co-euro equivalent if you're just avoiding a short bus trip,
Or hundreds of kilograms.
or several hundred kilograms of co-euro equivalent if you're avoiding a transatlantic flight and all the associated travel.
So a return flight from London to New York, for instance, represents a massive environmental liability that a successful virtual consultation just completely negates.
Precisely. If we are serious about sustainability, this tele-first model has to become a core part of clinical strategy. Physical travel should be reserved strictly for the things that absolutely need the patient to be there, the operation itself and the immediate post-op stay.
But everything else, the screening, the follow-ups, should default to remote care.
When it's clinically safe to do so, yes.
That's a new responsibility for many clinicians, though incorporating environmental impact into their decision-making. How do you advise they navigate that ethically?
It comes down to guidance and transparency. Clinicians need to be comfortable discussing the carbon impact alongside the clinical risks and the financial costs of travel. The ethics are quite clear because the virtual option is almost always the safest. It avoids travel risk, and it's the lowest carbon option.
So you're just presenting a fuller picture.
Exactly. You're protecting the planet, you're reducing the patient's logistical and physical burden, and you're maintaining or even improving clinical standards through better triage.
Moving from connectivity to continuity, let's talk about the problem of fragmentation. You've pointed out that missing op notes or incomplete medication lists when a patient returns home is a major source of medical error. This isn't just an inconvenience, is it?
No, it's a systemic patient safety failure. It's the single most common cause of communication breakdown in transitional care, whether that's domestic or international. We've known for years, from seminal work, that integrated digital systems dramatically reduce prescribing errors and ensure a complete audit trail for quality control.
And in a cross-border context where the local doctor has no relationship with the international surgeon, the value of that shared EHR just compounds.
It compounds exponentially. The primary value is in supporting a safe transition. Imagine a patient who's had complex spinal fusion surgery abroad. They have specialized implants. Months later, they present to their local GP with new pain,
The GP needs information, and they need it now.
They desperately need structured data. The exact make and model of the implant, any perioperative complications, the precise discharge medication schedule. Without a shared, accessible EHR, that local team is operating in a clinical vacuum.
And they're forced into what? Expensive, risky repeat diagnostics?
That is the reality. They have to rely on the patient's memory, which might be stressed or incomplete. They might order unnecessary, costly imaging or lab tests. I've even seen cases involving implants where semi-invasive procedures were needed just to identify the hardware because the records were inaccessible.
Which a simple, shared digital record would completely prevent.
It eliminates that costly duplication and, more importantly, prevents potential harm.
You've mentioned the Cleveland Clinic Abu Dhabi as an example of what's possible with high-maturity EHR integration. For the policymakers listening, what does achieving a high digital maturity, say HIMSS stage 6 or 7, actually enable clinically that a basic system doesn't?
Reaching that level is a massive commitment, but it moves the system far beyond just basic electronic charting. Stage 6 usually means you have clinical decision support integrated. Stage 7, the highest level, mandates key safety features like computerized physician order entry, which eliminates handwriting errors and gives you drug interaction alerts.
So it's about active safety features, not just passive record keeping.
Precisely. And crucially, these high-maturity systems integrate data seamlessly. At a place like Cleveland Clinic Abu Dhabi, the EHR means structured data implant barcodes, full procedure nodes, are immediately available across their network and can be securely sent to referring partners. The speed and structure of that data supports far safer post-return care than a fax paper summary ever could.
And I'm guessing there's a sustainability angle to this as well.
Absolutely. The environmental benefit is significant. Advanced EHRs obviously reduce paper use. But more profoundly, by allowing remote review of existing records, we stop the wasteful duplication of resource-intensive lab and imaging tests.
Every repeat CT scan avoided is a win.
Every time a patient avoids an unnecessary test because the data was already accessible, we save time, money, and environmental resources.
Of course, all of this depends on the secure governance of incredibly sensitive data. Health data is protected by some of the strictest rules in the world. What is the scale of the regulatory minefield that practitioners have to navigate here?
The complexity is staggering. A provider essentially has to adhere to the strictest data protection standards across 3 different jurisdictions.
3.
First, the provider's own country of operation. Second, the patient's country of residence. And third, critically, the location of any third-party cloud servers they might be using.
So you could be navigating, say, local data laws plus GDPR if the patient is European, plus the laws of whichever country is hosting the server.
Precisely. For a health system in the Gulf treating a European patient using a U.S.-based cloud service, the cross-jurisdictional complexity is monumental. It requires dedicated, expert legal and governance oversight. The penalties for getting it wrong are massive.
And beyond the regulations, there's the existential threat of cybersecurity. Ransomware attacks targeting hospitals seem to be constantly in the news. What practical steps do health systems need to take?
We're seeing these high-profile attacks because health systems hold such high-value data. The mitigation has to be multi-layered. It starts with achieving international standards, things like ISO 27001 certification, to prove you have robust security management.
And technically,
You have to prioritize things like multi-factor authentication, robust network segmentation, and frequent penetration testing. And when you're sharing data across borders, you should be using pseudonymization, not just simple encryption.
so you replace direct patient identifiers with a code.
Exactly. So even if that external data packet is intercepted, the identifiable information remains secure on your home system.
You mentioned trust earlier. With data crossing all these boundaries and facing these risks, how do we as professionals actually build and maintain patient trust in the system?
Trust is really the only currency that matters here, and it requires absolute transparency, far beyond the small print on a consent form. Patients need clear, jargon-free explanations about the life cycle of their data.
Things like who will have access to it and for how long.
Exactly. How will it be accessed? Who will have access? How long will it be stored, especially after they're no longer an active patient? And what's more, the health system has to provide a transparent dispute resolution pathway. If a patient finds incorrect information in their record or they suspect a breach, they need to know exactly how accountability will be managed, especially when legal action might mean crossing international borders.
That commitment has to be part of the clinical contract.
It has to be.
Okay, let's transition to how care is now shifting right into the patient's home. Remote patient monitoring RPM is moving critical care out of the hospital. How does RPM offer a unique value for the cross-border medical tourist specifically?
RPM provides a critical tether to the patient after they've left the intensive observation of the hospital. For the medical tourist who is thousands of miles from their operating team but still in that high-risk postoperative window, this technology is arguably at its most vital.
Because it's transmitting real-time physiological data back to the team.
Or near real-time data, yes. It allows the clinical team to maintain continuous objective surveillance of their recovery long after they've been physically discharged.
So the care team is effectively running a virtual ward for that patient's recovery. What specific critical complications can this kind of monitoring help detect early?
We're looking for those subtle deviations that come before a major complication. For an orthopedic patient, it might be tracking temperature trends that could signal a latent surgical site infection that only goes up a week after discharge.
And for other specialties?
For bariatric or cardiac patients, we'd be looking at daily weight and fluid balance via smart scales to detect early signs of heart failure, or monitoring heart rate variability that might indicate a thromboembolism risk. The combination of objective data with patient-uploaded wound photos and symptom diaries. It enables proactive intervention. That timely detection allows the international team to prompt a targeted referral to local services, often catching something hours or even days before the patient themselves would have realized how serious it was.
This sounds a lot like the hospital without beds model. Can you tell us about pioneering examples like Mercy Virtual in Missouri and how that model could apply to global patients?
Mercy Virtual is an excellent model of scale and centralization. It operates as a dedicated virtual care center, consolidating services like tele-ICU and remote chronic disease management from a central hub staffed by specialist clinicians. They monitor patients across multiple hospitals and hundreds of homes at once.
So a central command center for virtual care.
Exactly. And for global patients, similar virtual command centers really are the future of continuity. They could oversee the entire journey, manage the complex pre-travel risk assessment, coordinate care while the patient is abroad, and then transition seamlessly into intensive post-return monitoring.
So it transforms cross-border care from an isolated event into a continuous relationship.
A continuous, data-driven relationship, yes. It ensures specialist oversight is maintained, even if the patient is recovering in a small local hospital that doesn't have that subspecialty expertise.
That potential is incredible, but it must come with a huge data load. For the clinicians managing this, what are the big risks, like alert fatigue? How do you design systems to mitigate that?
Alert fatigue is a critical human factor. If your RPM thresholds are set too narrowly, or the system generates too many false positives, clinicians are just overwhelmed. They become desensitized, and there's a real risk they'll miss a critical alarm.
So you need smarter alerts.
You need intelligent, tiered alert design. The algorithms have to be constantly refined to reduce those false positives, and you need sophisticated filtering that only elevates the most actionable critical alerts. But you also have to balance safety with patient autonomy. The platform should have protocols that let the patient engage with and even temporarily pause monitoring. It gives them a sense of control and collaboration in their own recovery.
Let's widen the scope a bit and talk about the broader digital environment. These online marketplaces and patient platforms are often the patient's first and maybe most influential source of information. Where does the line get blurred between providing information and just aggressive marketing?
These marketplaces are powerful intermediaries. They can aggregate provider profiles, display accreditations, list prices, and if they're governed by independent bodies, they can genuinely enhance transparency.
But many aren't.
The challenge is that many are driven by conversion metrics. Search engine optimization, paid placement, heavily curated testimonials, they all risk distorting the clinical reality. The biggest risk is regulatory arbitrage. These platforms operate globally, often leveraging the weakest regulatory framework available.
So the most visible providers online aren't necessarily the safest.
They're the ones with the biggest marketing budget and the best SEO, which is not the same thing at all.
And this extends into the peer support communities on social media, which are completely unvetted.
Absolutely.
Cool.
Social media groups offer patients invaluable emotional support and honest advice. They share recovery photos, talk about their outcomes, but it's a vacuum for clinical vetting.
And it can normalize high-risk procedures.
It can. Or worse, it can encourage patients to ignore clinical guidelines, like traveling too soon after major surgery, or choosing a provider based purely on cost over safety.
So, as clinicians and policymakers, how should we engage with this powerful, consumer driven digital world? We can't just ignore it.
We have to engage actively. Waiting for patients to stumble into these potentially misleading commercial spaces is, well, it's no longer an acceptable position. Professional bodies, national health organizations, surgical societies, we have to proactively establish transparent, validated digital pathways and resources.
Creating clinician led forums or vetted comparison sites.
Exactly. We need to steer patients towards balanced, evidence-based information to counter the commercial hype. Our duty of care now extends into the digital public square.
We've talked about the immense potential of this technology, but it inevitably brings up new ethical questions around equity. If access to these advanced digital services depends on having good broadband, a new device, digital literacy, how does this new infrastructure risk making existing inequalities even worse?
The digital divide is probably the most significant ethical challenge we face in digital health. Access to safe, virtual cross-border care is just not universal. We saw this very clearly during the COVID-19 pandemic.
How so?
When services shifted heavily to video-based telehealth, the uptake dropped significantly among older adults, low-income populations, and people in rural areas with poor connectivity.
So, if the digital system is designed for the affluent, digitally savvy patient, it risks excluding the very people who might need the safety net of better triage the most.
That is the core of the issue. The digital divide impacts who can even discover these options, who can navigate the complex virtual intake forms, and who can participate in the video consults needed for safe risk assessment. If our advanced virtual services disproportionately benefit the privileged, we are actively deepening global health inequalities.
Let's talk about a related risk, algorithmic bias. If a hospital uses an AI model for, say, preoperative risk prediction, what are the clinical dangers if that algorithm was trained on a non-representative dataset?
This requires acute professional vigilance. An algorithm is just a mathematical reflection of the data it's fed. If a risk model for post-op infection was trained overwhelmingly on data from Western European or North American hospitals, it might fundamentally fail when applied to a patient from, say, the MENA region or South Asia.
Why specifically? Is it about genetic differences, environmental factors?
It's a combination of all those things. It could be genetic variations that influence drug metabolism or environmental factors like different baseline exposure to certain infectious agents. It could even be sociological factors like the accessibility of primary care after they get home.
So the model just misunderstands the patient's baseline risk.
And it will either mistriage them as high risk when they aren't, leading to unnecessary tests, or, far more dangerously, it will mislabel a high-risk patient as low risk.
Leading to things like inappropriate antibiotic prescribing or reduced monitoring. Highly dangerous.
Exactly. The consequence is a clinical error driven by biased data. This creates an immediate ethical obligation for us to ensure these algorithms are validated across the diverse populations they serve. As clinicians, we have to demand transparency. We need to know what the training set was.
This challenge must be compounded by the big multinational telehealth providers operating across dozens of countries. It raises huge governance questions. If a doctor in country A advises a patient in country B about a surgery in country C, who is legally responsible? Whose standard of care applies?
This is the governance vacuum that regulators are scrambling to fill. When care delivery is separated from the physical location of the patient and the doctor, the legal lines become incredibly blurry. Is the doctor liable where they're licensed, where the patient received the advice, or where the harm might occur?
There's no global standard.
There is no standardized global framework. So right now, it relies on transparent disclosure. The patient needs to know which professional license covers the advice, what the process for a negligence claim is, and crucially, what defines standard of practice, NICE guidelines, US guidelines, whatever it may be, is being followed.
So despite all this tech and data, you're stressing that the relationship between the clinician and the patient has to remain central. How do we make sure these virtual interactions still feel like genuine, compassionate human care?
Technology must always support the interpersonal aspect of medicine. It should never replace it. Patients who travel for care can feel incredibly isolated. That human connection provides immense psychological safety. We have to actively fight the tendency for virtual visits to become just transactional data exchanges.
It requires a sort of sophisticated website manner.
That's a great way to put it. It involves simple, dedicated practices. Maintaining genuine eye contact with the camera, not just reading the screen. Intentionally leaving unhurried time for questions. Actively inviting family members to join the call. The focus has to be on active listening and empathy, making the patient feel heard regardless of the screen between you.
Which brings us to a synthesis, really. The goal isn't technology for its own sake, but using these tools for a purposeful, integrated outcome.
Exactly. The final synthesis is integration. We have to leverage these tools, teleconsultations for better triage, interoperable EHRs for safe transitions, remote monitoring for post-op safety, all to ensure the patient gets the right care in the right place at the right time.
And it has to be done sustainably and equitably.
It must be. Technology implemented without clinical guidance and a deep commitment to equity risks becoming a costly distraction, or, even worse, a driver of harm.
That has been an exceptionally detailed and, I think, challenging discussion on the digital future of cross-border care. If you found this discussion insightful, please do take a moment to rate and share Deep Dive Ortho with your colleagues. Professor, you've guided us through the pillars: telemedicine for access, EHRs for continuity, and RPM for post-op safety. But for our listeners, the clinicians and policymakers who are defining this next generation of care, what is the one final crucial takeaway you want to leave them with?
My final thought is this. We must shift from passively observing the consumer-driven digital environment, the social media groups, the marketing platforms, to actively engaging with and guiding it. Our professional responsibility no longer ends at the hospital door.
We can't afford to wait for patients to stumble into misleading commercial spaces.
We cannot. Clinicians and policymakers must be the architects of transparent, validated digital pathways. We have to steer patients toward demonstrably safer, ethically managed outcomes. We must own the digital public square.
A profound point to end on. Thank you for this deep dive.
Thank you.
We'll catch you next time on Deep Dive Ortho.